Meet Kevin, a 68-year-old retiree who'd promised himself more time for walks, reading, and better food choices. He was the sort of man who loved quick, crunchy snacks while watching the news, nuts, crisps, or whatever was easy to grab. Recently, a buddy handed him a bag of roasted bean snacks, natural label, plant-based, high protein. Kevin thought, perfect, healthy-ish, and tasty. One evening, while watching a football match, he opened one bag, then another, then a third. They were irresistible. By midnight, his stomach felt odd, just a little uncomfortable and heavy, but he shrugged it off as overeating. The following morning, he woke feeling wiped out, with a pounding headache and a queasy stomach. He blamed the salt, but the discomfort grew into a dull, sharp pain under his right ribs. Drinking water didn't help. The nausea worsened and he couldn't face breakfast. By next day, his skin felt clammy and feverish. When he finally stood up, the room spun and he nearly fainted. In the bathroom, he saw something alarming. His urine was very dark, almost tea-colored. Looking in the mirror, his face seemed washed out. The whites of his eyes had taken on a yellow tint. His pulse was racing. Alarmed, Kevin called his neighbor, who drove him straight to the emergency department. You walk into the ED, and the first stop is triage. A nurse quickly records a brief history, checks vital signs, and decides urgency. Fever pl, right upper quadrant pain, pl's jaundice. That trio is alarmingly important. Clinicians immediately think of a dangerous bile duct infection called acute cholangitis, part of Charcot's triad, which can rapidly progress to sepsis. Given Kevin's appearance and unstable vitals, the team's first priority is stabilization, IV fluids for circulation, oxygen if needed, and empiric broad-spectrum antibiotics while they investigate. That's the mantra in emergency medicine: stabilize first, then seek the cause. An urgent abdominal ultrasound is ordered. Surprisingly, the biliary tree looks unremarkable, and there's no sign of obstructing gallstones. The initial impression leans away from cholangitis, so while the team keeps supportive care running, they dig deeper into Kevin's blood tests. Kevin's initial labs raise red flags. His hemoglobin is low, indicating anemia. Lactate dehydrogenase, LDH, is markedly elevated, a marker released when cells, especially red cells, are breaking down. His total bilirubin is very high, which explains his jaundice. But the pattern is telling. The direct conjugated bilirubin is relatively low compared with the total. That biochemical pattern suggests most of the bilirubin is unconjugated, produced by breakdown of hemoglobin, rather than caused by a liver or bile duct obstruction. Put together, the data tell a story. Red blood cells are hemolyzing. They re-rupturing in the bloodstream. Hemoglobin released from those cells is metabolized into large amounts of bilirubin. The liver becomes overwhelmed and cannot conjugate and clear it fast enough, so unconjugated bilirubin rises and the skin and eyes yellow. This is acute hemolysis, literally blood breaking apart. Next, the team works through causes. First, they consider external factors that can destroy red blood cells: immune-mediated hemolysis, mechanical destruction, for example from a malfunctioning heart valve, or toxins. Then they consider intrinsic problems that weaken red blood cells genetically, things like sickle cell disease or enzyme defects. Some tests, Coombs test for immune causes, platelet and coagulation studies for DIC and spleen imaging, are sent off, but many of those assays take time. Clinically, Kevin's hemoglobin kept falling, and he became symptomatic from anemia, so he needed a blood transfusion. Meanwhile, his renal function began to worsen despite fluids. A worrying sign. Free hemoglobin released during hemolysis is highly nephrotoxic. It can clog and damage the kidney tubules, and when it passes into the urine, it causes the dark brown color Kevin noticed. Preventing permanent kidney injury becomes another urgent priority. Some tests come back negative. Platelets and coagulation are within range, and the ultrasound shows a normal spleen without enlargement. No recent travel, no animal exposures, no new medicines and no bites. Those possibilities are crossed off. But the peripheral blood smear proves crucial. Under the microscope, the red cells look abnormal. There are blister cells and bite cells, where it seems like a portion of the red cell membrane has been removed. A special stain also reveals small dark inclusions inside some red cells called Heinz bodies, clumps of denatured hemoglobin attached to the inner membrane. These findings point to oxidative damage to hemoglobin and the red cell membrane. When Heinz bodies form, splenic macrophages surgically remove the damaged membrane fragment, producing the characteristic bite cell appearance. That pattern strongly suggests a red cell enzyme deficiency, most commonly glucose 6-phosphate dehydrogenase deficiency or G6PD deficiency. The team asks a targeted question. Have you eaten any fava beans or taken any unusual medications recently? Kevin digs in his pocket and finds the empty snack bag. Roasted fava beans. Bingo. The clinical picture fits. G6PD deficiency triggered by ingestion of fava beans, leading to oxidative injury, acute hemolysis, jaundice, hemoglobinuria, and transient kidney dysfunction. So what is G6PD? It's an enzyme found in all cells, but especially critical in red blood cells. It helps generate reducing power in the form of NADPH, which keeps glutathione in its reduced and protective form, GSH. Reduced glutathione defends hemoglobin and the red cell membrane from oxidative stress. Without enough G6PD, red cells can't regenerate that protective shield quickly. They become vulnerable to oxidant chemicals. Certain foods, fava beans, infections or some drugs can produce oxidative metabolites that push susceptible red cells over the edge. Why are red cells selectively affected? Unlike most cells, mature red blood cells lack nuclei and mitochondria and have a limited ability to make new enzymes. They depend heavily on G6PD to maintain antioxidant defenses. When G6PD activity is low, oxidant stresses cause hemoglobin to denature, forming Heinz bodies, and damage the membrane, prompting splenic removal and intravascular hemolysis. G6PD deficiency is surprisingly common worldwide. Hundreds of millions of people carry variants of the gene, especially in regions where malaria has historically been endemic. There's an evolutionary trade-off. Some G6PD variants make red cells less hospitable to malaria parasites, which partially explains why the trait persists in certain populations. How could Kevin reach age 65 without a diagnosis? G6PD deficiency exists on a spectrum. Severe variants cause chronic or neonatal hemolysis. Milder variants may be silent for years and only cause problems during a big oxidant exposure. Kevin AS form appears to be a relatively mild variant. He lived symptom-free until he binged on fava bean snacks. Back in the ED, treatment is both supportive and targeted. The first step is stopping exposure to the oxidant, no more fava beans, and avoid triggering drugs. He received IV fluids to support circulation and protect the kidneys, close monitoring of urine output, and a transfusion for symptomatic anemia. His kidneys were supported. Nephrotoxic insults were minimized and, fortunately, they started to recover once the hemolytic episode subsided and free hemoglobin cleared. No evidence of bacterial infection was found, so antibiotics that were started empirically were de-escalated. Over the next few days, his urine color lightened. His bilirubin trended down as the liver caught up, and his hemoglobin stabilized. After recovery, Kevin was counseled about G6PD deficiency, which foods, medications, and chemicals to avoid, and the importance of telling future clinicians about his condition. Family screening was recommended because it's inherited. With that knowledge, he could avoid future episodes and protect his kidneys and overall health. A few broader points. Oxidative stress is not universally harmful. Exercise, for example, produces oxidative bursts, yet is overall beneficial because it strengthens adaptive responses. But in G6PD deficiency, a particular oxidant load, like Fava bean metabolites, can overwhelm red cells. If you don't have G6PD deficiency, fava beans are generally fine in moderation. Kevin admitted he loved the flavor, and no, this isn't a sponsored plug, but now he knows to steer clear. If you enjoy medical mysteries like this one, there's a whole playlist exploring similar diagnostic puzzles that test clinical reasoning. Stay curious, stay safe, and I'll see you in the next video. Bye for now.